evening. We are thrilled to have you join us today to learn about the oral health of older adults living in skilled nursing facilities. My name is Marla Morris, and I am the Executive Director of Oral Health Ohio, which is an initiative of the Health Path Foundation located in Cincinnati. Joining me today is Abby Haynes, who is the Grant Manager for Health Path and provides administrative support to Oral Health Ohio. For those of you who are not familiar with Oral Health Ohio, we are a coalition of partners who work to influence policy and systems to improve the oral and overall health of Ohioans across the lifespan. Our work impacts Ohioans who face the greatest oral health disparities, which includes older adults. We encourage you to go to our website to become a member and learn about our work. I want to acknowledge the Delta Dental Foundation for making this webinar possible. Social work education often overlooks oral health, which is a critical gap. We are grateful to Delta Dental for recognizing the vital role social workers can play in improving the oral health of older adults. This issue is deeply personal to me, stemming from my experience as a quality assurance consultant in nursing homes early in my career. The agenda for this evening includes some housekeeping items. Following presentations by Dr. Mahalaha and Dr. Hemmings, I will moderate a few questions, then we will open up questions to the audience. We encourage you to put any questions you may have for the presenters into the chat box, which Abby will be monitoring. You will receive a link to the slides from today's webinar. The recording and the slides will also be posted on Oral Health Ohio's website. Continuing education credits are provided for this webinar. You should have received instructions for claiming CE credits yesterday. If you have not received an email, please put your name in the chat box followed by just the word CE, the letter CE, and we will get those instructions to you. There are no financial relationships to disclose for this presentation. The learning objectives for today's webinar are explain the unique oral health challenges faced by older adults, identify the connection between oral health and overall health in older adults, and identify at least 2 opportunities for social workers to integrate oral health into skilled nursing settings. It is now my pleasure to introduce you to our presenters. Rosemary Hemmings has a master's in social work and a PhD in public health. She has developed and teaches an innovative interprofessional curriculum related to social determinants of health, health equity, and social justice within the School of Dentistry at Oregon Health and Sciences University. Dr. Hemmings has presented her research nationally and internationally in the area of social determinants of health and social work curriculum within dental education. Suparna Mahalaha is a public health dentist who focuses on oral health care for older adults in residential, skilled nursing, and community settings. She is an assistant professor at Case Western Reserve University School of Dental Medicine in the Department of Community Dentistry. Dr. Mahalaha, I will now turn things over to you.
Good evening, everybody. Thank you so much for logging on in the evening hours of your day. Before we start, I just want a special thanks to the Delta Dental Foundation, Oral Health Ohio, and Marla Morris for being such a champion for all things oral health. Next, please. So a little bit about my background. I'm coming to you from sunny Cleveland, Ohio. We've had a heat wave here, as most of Ohio has, I think. I have spent time in federally qualified health centers for many years. I was a chief dental officer for some years. And I practiced dentistry in all public health settings, elementary schools, nursing homes, homeless shelters, adult day centers, and community clinics for the past 20 years. My career has sort of led me into the public health space, and all things public health have sort of shaped my career path. And I feel very grateful, for the places that I've been able to practice in. I'm currently an assistant professor at Case Western Reserve University, and I'm also a part-time nursing home dentist with 360 Care. And some of you may be familiar with that company in terms of the different services they provide in facilities throughout the country, actually. Next, please. So I have a lot of thoughts about being a nursing home dentist. I'm humbled by my patients every day. I have a lot of respect for workforce turnover, workforce staffing, and the different issues that, I see in nursing homes and long-term care facilities. I'm concerned about overall oral health management. I think there's a lot of room for improvement in interdisciplinary engagement and specifically with dental. I think there's more education and training that's required for those involved with direct and daily patient care. And, just even today, I was in one of my nursing homes today working with some patients. The social worker is the gatekeeper to these facilities. I'm always seeking out the social worker the minute I step into the building because they're the ones who know everything. I get to work daily with you all and I have immense respect for what you do because I know you do things that are way outside your job descriptions, all in the interest of the patient. So I thank you for that. Next, please. So poor oral health raises healthcare costs, affects residents' quality of life, results in unnecessary pain, suffering, and elevated risk of malnutrition, aspiration pneumonia, respiratory diseases, diabetes, and cardiovascular diseases. So these are all, related. Poor oral health contributes to bad breath and changes in dental and orofacial aesthetics. Poor oral health can alter speech and can affect self-image and self-esteem. And this comes along with serious psychological and social consequences. Next. So I guess the one takeaway, if you're going to take away one thing from this webinar tonight, is the mouth is very much connected to the body. We need to stop thinking of it as something separate. Older adults are more susceptible to systemic conditions, including oral diseases that directly or indirectly lead to malnutrition, altered communication, and increased susceptibility to infectious diseases, and unfortunately, a diminished quality of life. Next. All of this may seem very obvious, oral health and nutrition go hand in hand. With painful teeth and gums, it's hard to eat solid foods, then it's difficult to chew. Pureed foods can be high in carbs and sugar, and that cycle of decay starts. With no teeth or ill-fitting dentures, a balanced diet can be difficult. And not being satisfied while you're eating, this can lead to depression, isolation, and weight loss. And sometimes people will compensate, by eating soft processed foods, donuts, pastries, desserts, puddings, and these can all lead to weight gain. And again, not eating enough fiber because you can't chew properly. This can lead to constipation. Next. Periodontitis is another word for gum disease and diabetes and how these come together. Periodontitis is an infection of the gums that, if left untreated, causes redness, bleeding, pain, odor, tooth mobility, and eventual tooth loss. If a resident has diabetes, their mouths can be more susceptible to periodontitis. And because diabetes can slow down the healing process in general, periodontitis can be harder to treat. Diabetics should have optimal oral hygiene to prevent further exacerbation of disease. Next. Alzheimer's disease, as you know, is a devastating neurodegenerative disease that affects 1 in 10 adults over the age of 65. And there's 2 major types, familial and sporadic. A giant in the research field, Dr. Keiko Watanabe, is a professor of periodontics and researcher at the UIC College of Dentistry. And her recent study is the first ever to show that exposure to periodontal bacteria can initiate the formation of senile plaques that are found in Alzheimer's patients. So basically, this is suggesting that chronic oral bacterial infection or the presence of bacterial product in the brain can influence the development of these plaques. And then hence, this chronic bacterial infection may be a risk factor for the sporadic form of Alzheimer's disease. Next. Aspiration pneumonia. Wow, that's really small. My glasses on, sorry. Aspiration pneumonia occurs when oral and gastric contents are aspirated into the lungs, leading to infection. And this often results from impaired swallowing or protective airway reflexes. The common risk factors with aspiration pneumonia include advanced age, dysphagia, altered mental status, neurological disorders, and conditions that affect the gag reflex or esophageal motility. Nursing home acquired pneumonia is currently the second most common type of infection among patients in long-term care facilities in the country. This type of pneumonia is also responsible for a majority of emergency department transfers. Pneumonia represents 13 to 48% of all infections in nursing home settings. And residents with poor oral health can aspirate this plaque and, associated bacteria into the lungs. And this can be prevented with daily oral hygiene. Next, please. There are many oral conditions that are associated with aging. I can't get into all of them tonight, even though I'd love to. But I'm going to focus on dry mouth. So there's dry mouth, periodontitis, cancer, candidiasis, which is a fungal infection, caries, which is cavities, burning mouth disorder, and traumatic ulcers. Next, please. So dry mouth, we also call this xerostomia. This is, many older persons complain of a dry mouth and have diminished salivary output. The three most common causes of dry mouth are dehydration, polypharmacy, so taking in a lot of medications with all these side effects of dry mouth, and also anxiety and depression. If you look at the picture, of the tongue on the side over here, this tongue is very dry. It's like a desert. It feels like a bunch of cotton balls in the mouth. This feels as painful as it looks. Sometimes before I even walk into a patient room, I can hear the patient has a dry mouth because the oral tissues are sticking together and they make this little clacking sound, and I know it's uncomfortable. There's other causes for this decreased salivary flow: cigarette smoking, alcohol and caffeine consumption, other systemic conditions, and also radiation therapy to the head and neck region. Next, please. So there are many oral health challenges, that I've seen and witnessed and asked patients about. Residents sometimes does not receive a consistent twice a day daily oral hygiene. This could be a staffing problem. This could be priority of the patient or the aides. And is it a mandatory, part of the aides things that you have to do for the patient daily? And this consists of proper technique brushing, flossing, and tongue brushing. And there is an ideal way to do these things. And I know sometimes we can't do it in some of the settings, but this technically should be happening at least twice a day. The resident might have diminished motor skills and manual dexterity. So maybe they were effective independently before, in taking care of themselves, but they're not so effective now. And this might need constant assessment as well. I've heard, the sink is too far, the sink is too high, the chair can't fit under the sink, and I can't, move myself to get to the sink. When, some people really are very interested in still being fiercely independent. Some residents may not have a toothbrush or toothpaste, and sometimes they don't know who to ask to get a new one. Maybe this particular resident might have refused oral hygiene a few times, so now no one tries to help because they're deemed as, not cooperative, or they're not going to open their mouths anyways. Dentures are not being cleaned or removed at night. I see this a lot. People are sleeping in their dentures and they're not getting clean, and this then leads to yeast infections in the mouth. Again, a very preventable thing. Snacking throughout the night, I've seen this as well. For some of the patients, I'll go to their rooms, they'll have all these, pastries and puddings in the corner of the room to eat throughout the night during the day. And this leads to sugar that stays on the teeth, and then the decay process continues. Next. So I know you're all familiar with the MDS. I wanted to turn your attention to the dental part, the oral and dental part of the MDS report. And these are the different sections that the nurse or the person who does the intake form will be looking for when, a patient is admitted. Next, please. First, to look for broken or loosely fitting full or partial denture. If there's a broken denture or broken partial, this can cause pain, ulcerations, malnutrition, depression, isolation. And sometimes they'll also be looking to see if that denture is moving around in the mouth. Does it need to be adjusted? Does it need to be tightened? Those are all things that we need to assess. Next, please. The next section is to determine whether this patient has no natural teeth, or do they have tooth fragments or root tips that are remaining. And these are two pictures of, jaws that don't have teeth. We call this a dentulus. And I want to put your attention on the picture that's on the left. That particular lower jawbone, the mandibular bone, is atrophied. That's, the bone height is very low. So what happens is it's very hard to make a denture on, a jawbone that looks like that. So then you will find that this denture might be moving around a little bit, but this is what we mean when we call about an atrophied mandibular bridge, if you ever hear that. Next, please. Another assessment is abnormal mouth tissue, ulcers, masses, oral lesions. And, you wonder what's abnormal and what's normal. And, the person who's taking this assessment, are they able to distinguish between what's normal and abnormal? The top two pictures are pictures of lingual tori, which are bony protuberances that are, on the jaw bones. These are completely normal, but they can look a little bit, not so normal to somebody who might not know what they're looking for. And the third picture on the bottom is a tongue that's been pulled out to the right. And then there's an ulceration on the side there. There's many reasons for that. It could be a sharp tooth. It could be, a partial clasp that's, digging into the tongue. This could be something, lesion that needs to be inspected. And that's another thing that that's looked for in this part of the exam. Next, please. Obvious or likely cavity or broken natural teeth. So obvious decay, big black holes, chipped teeth, definitely easy to see. There's also other kinds of cavity that are not so easy to see. The lower left picture, is kind of chalky white teeth. This is the beginning of the cavity process. This is something, if the dentist is alerted earlier enough, we can do something about this and help stabilize it or turn it back. Next, please. Inflamed or bleeding gums or loose natural teeth. If the gums appear irritated, red, swollen, or bleeding, the teeth are coded as loose if they readily move, if light pressure is applied with a fingertip. And loose teeth are, a serious thing. For instance, this patient in the top picture, there's a tooth that's, was seen upon his chest x-ray, and that tooth is definitely not supposed to be in that part of the body. And the patient, swallowed this tooth. Or aspirated maybe. The second picture is somebody who has great oral hygiene, maybe used a hard toothbrush for most of his or her life and brushed away a lot of, the enamel surfaces. Now he's got root recession and these roots are exposed. This can lead to sensitivity. It can lead to a quickening form of decay as well. Again, that needs to be assessed and treated accordingly. Picture on the bottom is of a type of gingivitis, and this could be because the gums, or I'm sorry, the teeth weren't getting cleaned right at that gum line. This can be prevented as well. Next, please. Mouth or facial pain or discomfort when chewing. So if a patient can report this, this is great. Some of our patients cannot report this, so this might go undocumented in this report. Next, please. And then, the I don't know, and unable to examine, or if, the patient didn't open that day, maybe they couldn't do the assessment, or none of the above. Next, please. So when I look at that MDS section on oral health, there's no assessment of oral hygiene status. And I know that can be a moving target based on the day or the week or the month. And I'm sorry if that's not such an appealing picture. But, this is what I see. I see this often, and this is preventable. This can be cleaned off the teeth. And of course, there's a lot more that needs to be taken off with the hygienist and or scalers, or do some scaling root planing. But this can be managed, and it should be managed, and we should know that this is what we're looking for as well. On the right as well, I see the tongue being avoided a lot. Not a lot of tongues are getting brushed. This is a coated tongue, and this is very hard for a patient to be able to taste when you have this much coating on your tongue. And also this harbors a lot of odor. Next, please. So when I was thinking about the MDS section, I thought maybe I should talk to some of the nurses who actually, are working on this intake. And these are, the quotes that I got back from the nurses. The oral assessment seems pretty straightforward and we can do it quickly. We were trained to do this assessment by reading the steps for assessment instructions on oral health. We make an oral healthcare plan and it stays in the patient's chart. And side note here, as somebody who sees the patients, I've actually never seen an oral healthcare plan. So I don't exactly know where it lives. And that's, I'm doing a little bit more research myself and asking around more like, where is this oral healthcare plan? I want to see it. I want to see what it says. And maybe we need to change it, or maybe we need to add to it, or, delete from it. So that's one little side question that I have, and that I'm going to be doing a little more research on. Another thing I've heard is, our staff doesn't understand the connection between the mouth and the body. We could use more training. Can you come in and do an in-service? I started asking these questions and they're asking me, can you come and do the education piece? And a lot of the nurses told me, that we know daily oral hygiene doesn't always get done. Next, please. So this is a recent case I had. Not a denture that I had. I borrowed this picture from a colleague. But this is a 92-year-old female, has dementia and other comorbidities, and she presents as a new patient to me. I start my exam, I remove her upper denture, and there's a lot of plaque and food all over the denture. And on the inside, there's this black mold. She does not wear a lower denture. So this means that no one has removed this denture for maybe weeks and months because the staff thought they were her real teeth. So I went around and I looked for the aides, I looked for the nurses who were, taking care of this patient, and they didn't know she had a denture actually. So somebody had just been brushing over this denture, never removing it. So then this asks the question, did the MDS assessment reflect that the patient was a edentulous and wore dentures, or was the information not relayed to the right direct care staff? Next, please. So this is what I would like, this dentist would like you as a social worker to know these things. These are things that I think about a lot. Daily oral hygiene is just as important as bottom care hygiene. And I know I said it, sorry I did, but I think it's just as important. The decay process is exacerbated by the dry mouth environment. Saliva is protective. Saliva washes away food and sugars that stay on the teeth. And when you have a dry mouth, you don't have that, that capability. There are dry mouth rinses that can be prescribed and can alleviate some of these symptoms. I prescribe them all the time. When a dentist prescription orders are made, sometimes this information doesn't get to the nursing staff. So I wonder then, is there a communication gap? And I know every facility is different. I often am looking for the social worker or the nurse to find out, if that prescription order went through. I get this question a lot, even residents without teeth, do they really need to be still seen by the dentist? Yes, 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 yes. The oral screening must be done yearly because we do an oral cancer exam. We still need to look at those soft tissues in the mouth. We look at the bone in the mouth. We look at the cheeks, we look at the corners of the mouth. These are all things that we still need to make sure are looking, within normal limits. There's a wonderful, if you go back one, please. There's a wonderful tool that I use all the time. It's called silver diamine fluoride, SDF. It's a clear liquid that can be applied directly to the teeth to help with sensitivity and can also arrest the tooth decay process. This is wonderful for the treatment of older adults who cannot tolerate or cannot access routine dental procedures. I use this all the time. I think it's a wonderful agent to help stabilize disease and just kind of keep things quiet if we can, without more invasive procedures. I think the biggest thing I look to the social worker for is, to help be that oral health advocate in those plan of care meetings, because you get to be in on those meetings. I don't. So I'm hoping, if there's questions about, if your patient or your resident is acting differently or, maybe not as engaging, maybe there's some mouth pain, maybe there's tooth pain, maybe there's shame over, not having a tooth, or the denture's broken and I don't want to come out of my room because my dentures don't fit properly. Those are all things that the social worker can help, get that information to the right staff members. And I want you to know, as a social worker in the facilities, patients can be added to the dental schedules for whichever dental company comes into your building. They can go on as limited exams. Sometimes insurances will say you can have an exam once or twice a year, but if there's a limited emergent exam, we will always be able to come in and see that patient. You don't have to wait for the yearly or the twice a year exam that happens. And a limited exam could be a sharp denture, a denture that's rubbing, or a sore that's not healing. Please call us sooner than that if the sore isn't healing after 2 weeks. I had a patient the other day who had an infection at the corners of her mouth, and it just kept going and going, and she was in so much pain. An easy thing to treat, and it was really great. That particular social worker got on it and got us in early to treat that patient. So the goal here is holistic care. Care coordination and interdisciplinary collaboration are always welcome. I have a lot to learn from my social worker peers, and I'm hoping these are some things that we can maybe bridge the gap a little bit better, if you understand the oral health world a little bit better as well. So please be the oral health advocate in your facility. And next, please. These are my references, and I think we'll take questions at the end. Okay. All right. Thank you so much for your attention.
Ready for me? Hi. Hello, everyone. Dr. Hemmons, Rosemary Hemmons. I am coming from you from Portland, Oregon, where it's probably cooler here than it is wherever you are. I think we're pretty warm today. We're in the 80s, which is pretty hot for us. Next slide, please. As Marla mentioned before, I am an assistant professor at OHSU School of Dentistry, where I teach social determinants of health. I also direct a social work program within the School of Dentistry. The goal of that program is to really help shape the future of dentistry as we teach the dental students to always make sure that they are aware that the mouth is a part of the body and to provide holistic care to their patients. That being said, so what is social workers' role in dentistry? And I get that question all the time. What are you doing in the School of Dentistry? You're a social worker. I do have a PhD in public health, but so I always wanted to go back to think about why we went into social work in the first place and what are some of the core principles of social work practice. And I think what makes us unique from other healthcare caring professions is that we think about mind, body, and spirit. We think about really our foundations of our practice is based on holistic care. And, one of the things that I always want us to remember and that I tell social workers, my interns, is about social change. Social workers, we can work in many different sectors, many different fields, organizations. But social change is a core principle. And I think with that, we always need to think about advocacy. Sometimes I think we can, especially in the healthcare setting, we can feel that what is our role, right? We're not taking necessarily leadership roles within our healthcare settings with our residents. You have nursing staff, you have, medical staff, physical therapists, OT, and what is our role within that setting? And I think one of the crucial roles that social workers play in any setting they may have, but particularly within residential facilities, is advocacy. And I'll talk a little bit more about that later. Next slide, please. So Dr. Mahala mentioned this around the separation of oral health care from healthcare. And when you think about access to oral health throughout the lifespan, access to oral health care has implications for access to a dental provider, access to a dental provider who accepts your insurance, access to insurance that also covers dental insurance. As you know, a lot of when we think about healthcare and health insurance, it usually doesn't include dental insurance. That's usually something you have to get separately. I remember when I first graduated with my master's, 20-something years old, and I got my first real job and I had health insurance. Dental insurance was separate from health insurance. And I looked at what I had to pay out of pocket, right? And what I had to contribute to those coverage. So I didn't take dental insurance because I was like, why should I take that? I'll just take the medical, and I didn't take the vision either, right? So access to oral health care also includes cultural, economic factors, as well as geographic locations. People who live in rural communities may not be able to have access to a dentist. Also, we also need to think about healthcare policies on a national health. Conversations that occur around coverage for health insurance usually doesn't include conversations about dental care. Also, low health literacy. Low health literacy, not just for our residents and our families, but also us, right, as practitioners. What do we understand as it relates to the impact of oral health on the rest of our bodies? And how social work programs also, they don't teach you about oral health, right? When you're learning how to do an assessment in social work school, it doesn't usually include discussions around oral health. So these situations all contribute to why we see that there's a separation of oral health care from overall health. Next slide, please. The mouth is as a mirror to health and diseases. And I think Dr. Mahala talked about this, but what I really want to focus on is mental health, isolation, depression, anxiety, eating disorders, and substance use disorder. When we think about oral health, we don't always think about mental health. And in the school of dentistry that I work in, we get a lot of referrals from the dental students and the residents for patients who have mental health issues that's impacting their oral health, right? If you're feeling depressed, how likely is it that you're going to be able to focus on your oral health care? Brushing your teeth twice a day, you may not have the energy to do so. Isolation. Also, if your oral health is not in the best condition, releases self-esteem issues. If you're trying to seek a job, you may not go out to find that job, right? Because you're very self-conscious about what your oral health looks like, which contributes to depression and anxiety as well. Eating disorders causes acid erosions on the teeth. I teach dental students, how do you identify if one of your patients have an eating disorder? And one of the things to look for is acid erosions on the teeth, the tooth surface. Substance use disorder as well. And another thing to think about is chronic diseases. When most of your residents usually will have multiple chronic diseases. All of that also factors into the importance of making sure that their oral health care is up to par. Next slide, please. So what are some of the unique oral health challenges faced by older adults? We're living longer, right? If we're living longer, we want to have tooth retention becomes even more important, right? If you don't have your teeth, it's very difficult to eat. It's very difficult to communicate. So we want to make sure that as we're living longer, that we're also able to retain our teeth. I talked about this before, limited access to dental care insurance. As we know, Medicare does not include dental coverage unless you have an Advantage plan, right? When you get old, you tend to be more vulnerable. You're dependent on other people in terms of even having someone to brush your teeth. We see this in the residential facilities where a lot of residents are dependent on the CNAs to take care of their oral health care. Medication side effects. If you have residents who are taking psychotropic medications, that could impact their taste buds, right? So those patients, clients, you really want to make sure that you're paying attention to what their oral health care looks like. Dry mouth, Dr. Mahala talked about that before. Then I want to go back again to mental distress, self-isolation due to embarrassment, sleep disturbances, and poor concentration. If you're in significant pain, I don't know how many of you have had a toothache, but I have had a toothache, and it totally throws off your entire body. It's very difficult to function. So imagine if you are in a residential facility and you are dependent on other people to take care of you, and you're having such pain that you're not able to sleep. Think about what that behavior looks like. And it impacts your daily quality of life. Next slide, please. So what are some of the opportunities that social workers who are in skilled nursing facilities have to really incorporate oral health? So Dr. Mahala mentioned this, but the care plan, there's certain sections on the care plan that I think could be helpful. Section D, which talks about mood, to help you consider, maybe you need to take a look at this person's oral health. Maybe they need to be scheduled to be seen by the dentist. If they're having a poor appetite, possible due to oral pain, trouble concentrating, right? Changes in behavior, right? Section E, could also flag that there's some pain or there's some other issues going on that might be oral health related. The key here is to always think about oral health as you would think about any other reasons for why you're seeing a change in someone's status. Functional abilities, self-care, hygiene, someone who is not independent to take care of their own oral hygiene. You definitely want to make sure that, you're taking a look to see whether or not there needs to be an oral health assessment done. Do they need to be seen by the dentist? Also, as an advocate, advocate for your residents with the CNAs. I talked about health literacy. Sometimes, depend on your own lived experience, you may not really understand yourself the importance of oral health and how that impacts the rest of the body. So your CNAs may need some education around that. Section I, active diagnosis, neurological, nutrition. Talked about medications before, and so did Dr. Mahala. Mood changes and chronic diseases. Diabetes is crucial, cardiovascular disease. Residents who have had, joint replacements, very important that their oral health care be addressed, because the last thing you would want is for them to develop an infection in that joint. Right? Lost dentures. I see this all the time when I used to do mental health services in residential facilities, where a resident goes out to the hospital and they come back and their dentures are gone, right? Or they put it overnight in tissue and they put it next to their bed and the next morning it disappeared, it's gone. Think about the dignity and nutrition needs for someone who no longer has their dentures. I understand in Ohio, every 8 years, you can get reimbursement for a new dentures. And advocacy. Take the lead as social workers in your teams to talk about oral health. Always keep it at the forefront of every discussion that you're having with your team about residents. Okay, next slide. So here it is. Before I got into the School of Dentistry and started teaching there, I used to think that it was inevitable. Everyone loses their teeth as you got older, right? It turns out that's not true, right? So it's not normal that we have to lose our teeth as we get older. What prevents that is how we take care of our teeth throughout our lifespan. And as part of your assessments, as part of working with families, always try to get a sense of what was this person's oral health care like throughout their lifespan. Did they see a dentist on a regular basis, right? Did they have dental insurance, right? A lot of that information can give you a sense of where that person's oral health might be. Before they came into the facility, when was the last time they saw a dentist? That's a trigger. Maybe we need to make sure that we get this person set up to see the dentist the next time the dentist comes in. So if you take nothing away from what I said today, is just always think about your role as an advocate for people who are not able to advocate for themselves. And how do you use that advocacy role in every situation within the residential facility? Next slide. Thank you.
Thank you both very much. So Abby, let's stop sharing maybe and we can start a discussion. I'm going to ask I don't see any right now questions in the chat that any of the audience members have, but if you have a question for either Dr. Mahalaha or Dr. Hemmings, please put it in the chat. I do have a couple questions that I want to ask both of you. What we heard throughout, both of your presentations was, Dr. Mahalaha, you talked about you've never seen oral health as an entry on a care plan. And also Dr. Hemmings, you talked about the need to incorporate oral health in part of the psychosocial assessment. The quarterly care plan meetings that the interdisciplinary team has, could you both maybe talk a little bit about the care planning meetings as an opportunity for a social work advocacy, or Dr. Mahalaha as an opportunity to integrate oral health?
Mahala, I'm going to let you go first.
Okay, so unfortunately, I'm not part of those meetings, so I don't exactly know what the meeting is usually about. But I would say, if there's an opportunity to ask about an oral hygiene assessment, because we don't have a baseline. Like when the patient comes in, is their oral hygiene, is it fair? Is it good? Is it bad? We don't know if it's gotten worse or better in the time that they've come in and stayed. So that's one thing I think about a lot. And also in that meeting, if it's possible for the social worker to advocate, to if a patient has not, I think what Dr. Hemmings just said also, if a patient has not been seen, perhaps generate a list of those patients who you are seeing that, have not been assessed for a while, or they were only seen as limited exams or emergency exam, but not full comprehensive exams, because that's a much more detailed exam. So I would say if you could have a running list of these patients to then, take that to the people who make the appointments with the dental company or the dental providers that come in for you and make sure they get on the list. I would say that.
Yeah. And I would say, during these meetings, important because you yourself may not, I mean, if you have recognized, if you've noticed changes in, as you look in the care plan, someone's mood or their behaviors, and this is being discussed in the meeting, I would say to actually say to the team, when was the last time that this resident saw the dentist? Right? Maybe there's something going on with their oral health, whether it's because of your observations personally of this resident's changing their mood or their behavior, or someone else on the team is bringing up, something about that they've noticed that there's some changes with this resident. It's a good idea to actually say, maybe we should consider getting a dental referral for this individual, for this resident. The other piece that I think is just so crucial is the focus on the personal care, the hygiene, right, of the resident, and really who is the person who's responsible for that? Who takes care of that? And we need to always make sure that we are connecting with the CNA, if that's who it is, usually is from my experience, to make sure that the oral health care, the hygiene is actually being included in their overall hygiene care. We can't always assume that, our CNAs are aware of just how important. They know that they should do it, but do they really understand the ramifications for not really paying attention to the oral health care hygiene of each of those residents? So that's what I would say.
Well, thanks, Dr. Hemmings. And that brings up an issue that I'm going to ask one more question, and then there's a couple of questions in the chat. Dr. Mahalaha, what comes up very frequently is how when somebody may be cognitively impaired or is not able to follow directions around oral hygiene, what is the aide to do? How does the staff approach that kind of a resident that is having those challenges?
I think in that situation, and it happens all the time, I think a dental consult is the first step there. So meaning if a dentist or the dental hygienist can come in and, assess that patient, sometimes try some different techniques to have the patient open, or even just start small. So there's just a couple of weeks ago, I did something similar where patient wasn't opening, they couldn't get the oral hygiene done. And I just worked with the patients for about 10 minutes, and we only did like one section of the mouth. We only cleaned one section of the mouth on that visit. So it was almost just going a little bit slower with this patient. And hopefully now the patient will, or the resident will now let the aides, clean a little bit, even if it's one corner of the mouth, great. So I would start with the dental consult and truly see if it's maybe a different way we could access. We could put the toothbrush in the mouth. Maybe the head of the toothbrush is too big sometimes. Sometimes the patients want to hold their own toothbrush, so we can modify the toothbrush if they can't grip properly. And that's something we can do as well. And sometimes why the patients might not let somebody else brush their teeth.
Yeah, and we have to also remember that our experience with that resident may not be the same when they're seeing a dentist who is trained, right? We have to remember that all of these dentists and dental providers who are coming in, they're trained to work with this population, and they can help us in understanding how we can better get this resident to be able to get their oral health care needs met that we may be struggling with. Right? Or a CNA may be struggling with.
Thank you. Okay. We do have some questions in the chat. So they both look like they're insurance questions. One is, what is the cost for the tooth coating? And does insurance usually cover? Can this process be completed in the patient room? And they might be referencing silver diamine fluoride, I believe.
So the cost for this is covering silver diamine fluoride. Medicaid does cover this. Some of the insurances don't cover. It all depends on what in that particular facility the patient's insurance is. Most of the patients that I see in the facilities have some sort of insurance that does cover the silver diamine fluoride, and some are also private pay where we work through the I believe the company that I work for, works through the nursing staff and then the social worker to let them know what that private pay is on that particular silver diamine fluoride application. And that number does vary in terms of cost. And this process can be completed in the patient's room. That's what's so great about it. I can do it anywhere. I've done it in hallways. I've done it in the beauty salon. I've done it wherever. It basically is a little brush that we dip in the clear liquid after we clean off the teeth, and I'm able to apply that on the tooth surface that requires that application. So very easy to apply. And I wish we would use it more and could use it more because it really is wonderfully effective.
And Dr.
Thank you.
Mahalaha, the SDF, it stops the tooth decay, and it preserves the tooth until perhaps additional treatment may be needed, right? Is that correct?
Correct. And in some patients, we can and we probably should apply at different intervals to make sure that it's really, kind of soaking into the tooth. And it's a perfectly good treatment for a patient who cannot tolerate, a big filling in the back of the mouth or a crown, or, it's a really great stabilizer. And I have plenty of patients who have, we've been able to stabilize that way and have not had to extract certain teeth because we can manage and stabilize them that way. But of course, that does need the dentist looking in on that every 6 months to make sure it hasn't progressed or it needs some other kind of treatment.
Thank you. Okay, this is from Susan Lawson, and she wants to know if, how many of the residents have dental insurance and how many may have Medicaid. Some of those folks may be dual eligible, Medicare, Medicaid. And what happens if one of the residents does not have insurance?
Hi, Susan. It's great to hear from you. So again, that would be a great question for the office manager in terms of how many of them have insurance. But my experience is that most of the patients that I see in facilities do have some sort of insurance that does cover, even like the basic dental procedures. And if the patient doesn't have some sort of insurance, then they're deemed as private pay. And then they work with the office, and usually a payment is provided before services. And then if there's more things that need to be done, then like a treatment plan is provided, and it's related to the family then.
Great. Susan, also the question, does the CNA have oral health training? Which I'm going to take a stab at this because
Please do.
okay, so CNAs, we a couple years ago, we commissioned some dental hygienists to rewrite the curriculum for how the oral health curriculum and how nurse aides were trained in oral health. And we had that passed as a rule change in the Department of Health. And this is a comprehensive approach to the patient in terms of their oral health, from the dependent to the independent resident all the way to the dependent resident. And we actually have one of the authors of that work on this call today, Luke Burrows. What happens is now it's a rule. It means it has to be taught. And one of the things that Oral Health Ohio is going to be doing next year is following up with all of the CNA training programs to see, is the rule being taught, is the curriculum being taught? And if so, what, if any impact is it having actually in the nursing homes? And so we'll be surveying both the training programs, CNA training programs, and nursing homes in Ohio. So that is something that that we're doing on a broader statewide level. But I think something that Dr. Hemming said is really important, And that is that some of our CNAs may not themselves understand, and even it could be any other staff member within the nursing home may not understand the importance between oral health and overall health. And so it is something that might be, you know, and we know that the aides are very busy, and oral health is something easy to fall off very quickly. So I didn't know if Dr. Hemmings or Dr. Mahalaha, you wanted to say anything more about the training of CNAs.
Yeah, I was gonna say that part about how it falls off. I mean, when I used to go into the residential facilities, CNAs would say to me, well, I didn't have time to do that because I have 15 residents today,
Mhm.
right? So something had to go. And usually what went was the oral care of that, of that resident. So I think that's why it's so important for us as social workers to really take on that role of advocating for the importance of the oral health care of the residents. And I don't really know what the demographics is in Ohio as it relates to your CNA, but from my experience in Florida, New York, even here in Oregon, interestingly enough, that a lot of our CNAs tended to be from other countries. They were immigrants, right? And oral health is viewed differently depending on where you came from, right? And so that then also factors into how you care for someone else's oral health, right? So we need to take that into consideration as well.
Thank you. Thank you so much. The other thing I just wanted to let the audience know is that Oral Health Ohio is working to bring an interdisciplinary oral health program. It's evidence-based in Maine to Ohio. We're currently seeking funding for this, and it's having a tremendous impact on the oral and overall health of nursing home residents in Maine. And so we're working on that as well. So hopefully, we can bring that program to Maine and then scale it. I think we have time for maybe one more question, and Dr. Hemmings, this is for you. You mentioned that families can be a resource in understanding a resident's oral health history across the lifespan. And
Yeah.
that history is important to the psychosocial assessment, right? If people as children and adolescents and adults didn't have access to a dentist, obviously that's important in terms of understanding that. Can you discuss how this information might be able to be turned into action by the social worker when we better understand oral health across the lifespan?
Yeah. Yeah, happy to. It's not natural for us as social workers when we're doing our biopsychosocial assessments to really ask about oral health, right? So I think it, requires a change in the way in which we view our assessments. And that being said, when we sit with a family and we are completing that assessment, that we include questions around, like I said earlier in the presentation, when was the last time this person saw the dentist? Do you know what their access to dental care was throughout their lifespan, right? Do you know if they've had any issues with their mouth, right, that you might be aware of, right? And taking that information, and that helps you to be able to determine whether or not this is someone that may need closer attention for their oral health care, right? And sharing that information with the team. And also, like we said earlier, schedule it, making sure that they have an appointment scheduled to be seen by a dental provider, especially if they haven't seen one in the previous 6 months. I know some insurance, they will allow yearly visits. I don't know what Ohio's Medicaid covers, if it's annually or every 6 months for follow-up visits. But I would say, within the previous 6 months, because by the time they get an actual appointment to see the dentist, it will take some time. So I think that feeds into helping us understand what we need to be aware of moving forward as we work with this resident, and what the other disciplines also need to be aware of. And when we are writing those assessments up, and we're sharing that assessment, we should actually call out that information around oral health. The same way we would call out, this person has been taking, Prozac for depression, right? We would also say, and they have not seen a dentist in over a year, or they've had issues with, their oral health before, right? Oral cancers, mouth sores, missing teeth. Even though we're not quote unquote medical providers, it's okay because we're thinking about holistic care. Because if someone has missing teeth, that impacts their ability to eat, right?
Yeah.
So it
Thank
all
you.
matters.
Yeah.
We're not going to separate the body based on our discipline.
Right. And it also seems that asking that information in the assessment, when the social worker is talking with family and we're getting that information, that is also going to alert, seems to me, the social worker that whatever information you're getting may be an opportunity to understand whether the family and or the resident needs some education around oral health literacy.
Right.
Yeah.
And you certainly can explain why you're asking the question, right? I'm going to ask some questions around their oral health because a lot of things that happens to the body starts in the mouth. That's education right there, right?
Great. Well, we're just about time. I want to thank everybody for being here, and we're so grateful. We're so, Oral Health Ohio is so happy that you want to engage around oral health, and it's such an important part of overall health for our older adults. So, for those of you who put your names in the chat, I will make sure that I get you that link to CEs tomorrow. I know that some folks, your emails bounce back to me. I'll double check those, but if not, I will get in touch with your organizations. If you do not hear from me by tomorrow, for those of you who put your names in, please email me directly. I'll get the slides out to all of you tomorrow, and email me directly that you didn't get information from me on tomorrow, because I want to make sure that you get your CE credits for being here tonight. Thank you so much.
But one more thing,
Oh.
even though we're talking about skilled nursing facilities, right? We know that we have residents who are there short term, right? And those who are there long term, right? And I think the assessment and work with the family and education is so much more important for those who are there short term, because where are they going back to after they leave you? They're going back home to their families, right? So it becomes even more important, for your residents who are only going to be with you short term.
Thank you, everybody. I'm wishing you all a lovely summer, and we might see some of you on next week's call for older adults in community-based settings. Thank you.
Thank you.
Hi,
Good night.
thank you.
Thank you.